So hi and welcome to Lessons from the Grand Rounds. In this short video, we are going to talk about cytomegalovirus infection in hematology patients or hemato-oncology patients and also in post-transplant settings. So this video will help you understand the spectrum of presentation in hematology or hemato-oncology patients. We'll also discuss about the prophylaxis and the treatment of CMV infections. So let's talk about four important case scenarios which I have seen throughout my residency. So the first case scenario is a case of post-transplant patient who is day plus 560. So this patient comes with complaints of low-grade fever since the last 2 weeks, generalized malaise, and while we are screening the patients every weekly till day 90, that is 3 months post-transplant, we see that the CMV copies initially were just 500, now they are around 15,000. So and the other infective causes are ruled out, and this is a case of CMV infection in a post transplant haploidentical transplant. So this is as basic as presentation, where the patient just has some febrile illness, low grade fever, generalized weakness, malaise. So this is one of the basic presentation of CMV infection. The second scenario includes a case which is a 50-year-old male who is he's a case of DLBCL relapse refractory post two CAR T therapies and now allo HCT. So he is around approximately around day 180 post transplant, and he has history of acute GVHD before, and now he has come with complaints of um, loose motions, blood mixed stools, and the colonoscopy is done. The patient turned out to be grade 3 GVHD, gut GVHD based on the biopsy. This patient receives therapy in form of immunosuppression. 4 weeks later, the patient again presents with uh, loose motions and also blood mixed stools, which is very profuse, which is very persistent in spite of the steroid therapy and the immunosuppression. You rule out C. diff colitis as well. You do a colonoscopy again. You take a biopsy. The CMV stains comes out to be positive. Here, the CMV in the blood was negative, whereas when we did a biopsy, there were cytopathic changes, viral cytopathic changes of CMV on the biopsy, as well as the biopsy CMV stain was positive. So this is a case of CMV colitis on top of grade 3 gut GVHD. So here the moral of this case is that in a case of chronic GVHD, when there is new onset diarrhea or GI symptoms, which where we have ruled out GVHD, the patient is on GVHD therapy, and we have ruled out other infective causes including C. diff colitis, we should suspect CMV colitis because we have already hiked up the immunosuppression. The patient is at high risk of CMV reactivation. So the third case involves a 50-year-old female who is a case of relapse refractory myeloma post multiple line therapy treated post transplant. Now she is on teclistamab trial. She has received 7-8 doses of teclistamab. She was admitted previously with multiple viral infections, URI, where rhinoentero was detected, and she received multiple IVIG sessions as well. Now this patient has come with complaints of cough, which is persistent since the last 15 days. Also, the relatives mentioned that she has intermittent daytime sleepiness since the last 3 days. So what we do is we check for the CMV as a part of evaluation for this patient. The CMV blood copies are around 6,000. Then we also do a BAL for this patient. The copies are around 40,000. The patient undergoes CSF for some behavioral changes, some sleepiness. CSF analysis, you see that there are 50,000 copies of CMV, and this point shows you that this is an approximate case of a disseminated CMV infection post teclistamab therapy, where the BAL CMV copies are significantly high. This patient had history of previous viral URI before, and this patient also has a documented evidence of CMV encephalitis with clinical features, whereas a CMV in the CSF is also positive with significant amount of copies. So this is one case where the patient has CMV pneumonitis, CMV encephalitis, and probably CMV disseminated CMV infection. So this was the third case. The fourth case is a case of ALL, um, acute lymphoblastic leukemia. On maintenance therapy, he is put on POMP therapy where he is put on methotrexate, 6-MP steroids. So this patient, originally from Nepal, he is admitted there with complaints of 3 weeks history of fever, cough with expectoration. They treated him with IV antibiotics. The uh, CBC shows pancytopenia. He has organomegaly. He has persistent fever spikes more than Tmax of more than 103. This patient also has ferritin of 18,000, and here we are suspecting HLH for the patient. The bone marrow is done. You find hemophagocytosis. You find all the other infective causes. This patient later is found to have 5 lakh copies in the blood of CMV. So this is a case of secondary HLH in adult, secondary to CMV reactivation. So I've formulated 4 cases where we have discussed simple febrile illness post-transplant as a presentation of CMV, followed by uh, a gut GVHD refractory case presenting as CMV colitis. Then we have a case of disseminated CMV infection, and then we have a case of CMV presenting as a form of HLH. So CMV presentation can be as simple as a febrile illness with malaise to CMV pneumonitis, CMV encephalitis, disseminated CMV infections, or a cause of um, HLH in immunocompromised patients. So the incidence is significantly higher in allogenic stem cell transplant as compared to autologous stem cell transplant. And what we do in allogenic stem cell transplant is we check the CMV status, that is we check IgG, IgM of the patient as well as donor. So when the donor is negative for CMV, is not exposed to CMV, we usually avoid these type of donors. So how do we monitor, how do we how do we do a surveillance to detect the CMV early? So in all allogenic stem cell transplant till date T plus 90 post transplant, that is 3 months, we check CMV weekly. So blood CMV quantitative PCR is checked weekly. So the this investigation, the quantitative PCR, is highly specific, but the sensitivity goes down in cases of CMV colitis where the tissue biopsy is important, and we usually require a tissue biopsy, except in cases of CMV retinitis where the ophthalmic changes are very much specific and we don't need a tissue diagnosis. So, as said, CMV colitis, CMV pneumonitis, the peripheral blood CMV levels might be low or absent, and we might require a tissue diagnosis or a specific tissue like BAL, specific sample like BAL to detect the significant copies and prove the diagnosis. So what do we do usually for prophylaxis for CMV is, so at our center what we do is for all the haploidentical transplant patients, or all the mud transplant patients, or the patients who have received ATG as a part of conditioning which increases the risk of CMV reactivation, these patients are kept on letermovir prophylaxis. So when we are kept with CNI, we give it 240 mg once a day. Um, so that time 240 mg once a day till day 19 is the uh, prophylaxis of choice as of now in haploidentical transplant, in mud transplant, and also in transplants where we use ATG as a part of immunosuppression, which increases the risk of CMV reactivation. So now let's discuss about the treatment therapy. So in treatment we have 3 major drugs, which is ganciclovir, valganciclovir, foscarnet, and also cidofovir, and the other drug is mirabavir, which we don't have in India. So ganciclovir is the drug of choice. It is given IV 5 mg per kg twice a day for 14 days, and we usually check the CMV post 2 weeks, blood CMV post 2 weeks. The major side effect of ganciclovir is the myelosuppression. So in patients whose disease is significant, which involves the marrow and has cytopenias already, 5 days of ganciclovir will suppress the marrow and cause grade 4 cytopenias, grade 4 neutropenias, which will again expose them to the risk of neutropenic fever or bacterial infections.